How it goes. Can you hear me using this one? Let me know if you can't. I'm Jannie. I'm an adult physician from Denmark, and I'm very pleased to be able to participate in this meeting today, and thanks very much for the invitation to be here. I've looked forward to it. So I'm going to tell you a little bit about the background for my work in OI and for being here, and for the stuff I'm going to tell you today. I'm going to run through a few studies that we've done in the adult population in Denmark to bring a little bit of an international perspective on things. Probably, maybe not that different really, but we'll see. And then bring you some results on quality of life. And we can discuss whether there's a need for follow-up care to determine this. So I'm an adult endocrinologist. I'm located in Northern Europe, in Denmark, the Western Denmark, in Aarhus. And I've got the opportunity this year to spend some time in Sydney. Traveled with my husband and 3 children to Sydney, and yeah, that's all a big adventure for us. And then I've been fortunate to come and do some observation and a little bit of research with Professor Mons. So that's turned out to be a very exciting and very good year for me. As an adult endocrinologist, the patients that I would usually see in my outpatient clinic would be the old ones, the people with age-related osteoporosis, but then every now and then younger people will turn up. Oh, should I take this one instead? Yeah. Is that better? Can you hear me? Yeah, I like that one. So every now and then younger people would turn up in the clinic, and that would always make me wonder, what's going on here? Is it just bad luck, like an early age-related osteoporosis, or is it something else? Is it OI? Is it other things? What's going on here? So in terms of osteoporosis, the bone mass is reduced, but it could also be the architecture in the bone matrix that could be affected as an OI. When I was a very young doctor at the endocrine department in Aarhus, I met the first couple of young people with OI in the clinic, and I didn't remember an awful lot from medical school about OI, so that got me curious, and I started to read about these things. And luckily, some very clever people had written a lot of stuff about OI through an awful lot of years, and that's just fortunate when you're interested in a field as a young physician. It's good to be able to read about these things. So as you're all familiar with, OI is inherited, and it's related to the collagen encoding genes. There's a great variability, and that's probably the thing. That was the thing that caught my attention, at least, and everybody wonders that. Why is that? Why is the heterogeneity so impressive? It's all, or most of it, is down to the collagen protein that's in a lot of tissues, in fact, in the body, and in particular in the bone. So it makes up, the collagen proteins make up this kind of scaffold for the bones where the bone minerals can lie on. And then some types of OI would have a normal appearing protein, but too little of it. So it would have gaps between the protein. This is just a schematic drawing. It's not real life. That's the way I think about it. Whereas this would give a more mild phenotype, and then you'd have the abnormally shaped proteins that would give you more the moderate severe OI. So that could cause some of the differences. And that's why we're classifying this using Dr. Sillen's classification that's been globally used within the last many years, and still the easiest way of classifying different types of OI. So Denmark is much smaller than Australia. We're 5.7 million people just around. It's predominantly a public tax-financed healthcare system. We've got around 500 people with OI. Last came to 600 and something. I'm aware there's a little bit of misclassification. We've got these registers, and they're very handy when you want to do research within OI, but they're not perfect either. So, but around 500 would probably be close. People with OI in Denmark are followed at a Center of Rare Diseases during childhood, and they're located in Copenhagen to the east and Aarhus to the west. When you transition into adulthood, adult care, you're followed at one of 3 different endocrine departments. There's one in Copenhagen, there's one in Odense, that's where Lars Folkestad is located, and then one in Aarhus where I'm working. So it's, I think, very similar to here in terms of childhood care. And I want to remind you I'm an adult physician, so I don't want to say any smart things about childhood care, but my experience is that they're very careful with their work, and they've got these centers where they meet from different specialities, followed by the pediatrician that takes care of the child, of the family with OI, and does that very carefully through the childhood years. And get the orthopedic surgeon or people from other specialities, doctors from other specialities, physios and so on, to see the child in the clinic. And then we've got the adult endocrine department, where an endocrinologist is located together with a specialized nurse. And then we can refer to the different specialities when needed. And then between 15 and 18 years of age, the transition takes place from the pediatric department, from the Center of Rare Diseases in Denmark, and to the adult care. But then we worked out, that's about 10 years ago, we started looking at this. And something happened. The transition didn't really occur, and actually Jannie was mentioning the same thing. It was like the patients, the people with OI, they didn't turn up the adult service. So they may have been referred to us, but we didn't see them. And there was an obvious explanation, was that our offer wasn't good enough. We weren't able to do all the careful follow-up as they definitely did in the pediatric department. So, and then, of course, as well, it's the young adults were pleased to escape from the time at hospital and wanted to do their own experiences, and so a lot of things happened in those years, and that was an obvious problem, because when I would see the patient, or when my colleagues would see them in the clinic again, they would come back with a very severe fracture, and it would turn out that maybe the years hadn't been that good, like health-wise. It'd been nice to be away from the hospital system. It's been nice with a sort of a break, but nobody had followed, nobody had done all the careful follow-up that had been taking place all through childhood. So that was some of the motivation for doing the studies that we started. We had quite sparse knowledge about OI in adulthood, and to some extent I think that's still the problem. There's a lot of things that we don't know. So we thought first of all, we need to make a better offer for the young adults, to do something at least, and to focus our evaluations so that they would make sense and they would help that person with OI. So we wanted to improve the transition from childhood and into the adult care and try to avoid the dropout that was definitely taking place. And then we had some new equipment that we wanted to use, some new techniques that we could use to evaluate this group of patients. So we decided to look at the adult follow-up and plan some research to take place, but we wanted this to be relevant to the people with OI. And as you have here, and this is a great example, we have a society of, like a Danish OI society, DFOI we call it, and we invited them for a meeting because we wanted to discuss with them what to do, how to engage how to make these studies better and good in the planning process. So we got some good input at an early stage before before starting these studies. DFOI in Denmark has currently 300 members, and 121 have OI, and some of them are children. So we talked to the chairman of DFOI, who is a very small man with he's very clever, he's got a very big heart for OI. So he's been extremely helpful, Carsten Jensen, been extremely helpful throughout the process, been attending numerous of meetings and helping us along the way as we started planning this OI adult service. So we wanted to look into the skeletal issues, the fractures and growth, pain, deformities and so on. And we wanted to look into the things outside the skeleton, because as we already discussed, collagen, the collagen protein is located in a number of tissues in the body. So we wanted to look into the eye issues, the teeth, the hearing, maybe the ligaments. And then we decided to look into, if you can, a quality of life. That's very popular, but it's a really difficult measure to obtain and to I think it's difficult to say what's good quality of life. It's individually certain, but it's people have described this as being affected somehow in OI. Seedorf wrote that people with OI have a certain positive attitude towards life, and they've been described as survivors, surprisingly normal in their attitude towards life and with a skilled ability to cope and adapt. And I don't know where that comes in, but it's probably something you've all heard mentioned before, and I know people have doubted it as well. Could that be? But anyway, we wanted to look into the quality of life somehow. So we did a cross-sectional study. We invited all the patients that we knew in Denmark in for evaluations, and we asked them to take part. They had to be above 18 years of age. We advertised in the magazines and looked through the databases and found a little over 100 with OI. 91 participated, and we ended up excluding 6 of them simply because we didn't think that they had OI anyway, but they were registered with OI in the registers. So 85 adults between 18 and 78 years of age, and they came from all different sides of the country and different parts of the society. So they accepted to participate. We evaluated the genetic cause of OI and found collagen-related mutations, so changes in the collagen coding genes in all but 4 patients, I think. So we evaluated the bone by blood samples, looked at vitamins, looked at a whole number of different factors that can affect bone. We did DEXA measurements that you're probably all familiar with. We did an volumetric BMD HRPQCT, where you look at the 3-dimensional bone on your lower forearm and lower leg, and we did a spinal X-ray. We found these 85 individuals to belong to 66 different families, so obviously some of them are related. It's a small country. They were similar in terms of gender and age, and we found the expected differences when we looked at height and weight and number of fractures. So looking at the DEXA result, the 2-dimensional bone mineral density, we found that the type 3, or the people with the most severe OI, had a lower bone mineral density compared to the mild and moderately affected ones. But we couldn't discriminate between the mild and the more moderately affected with OI. Looking at the 3-dimensional bone scans, the PQCT on the forearm and lower leg, it was a little bit different. We saw that the people with type 4, the moderately affected ones, had a higher volumetric BMD, 3-dimensional BMD, than the milder affected ones, and then the severe and the severe ones. So that was a bit of a surprise for us. I brought some images from one with mild OI, type 1, type 3, and type 4, where you can see the trabecular on the inside. That network of bone is different in the mild one and in the severe ones compared to the moderate ones. So why is that? Can we use the PQCT results to say something about the collagen morphology, like the type of protein that's affected? Well, it's probably a little bit like a building site where you've got these metal frameworks, what do you call them, and you've got concrete around them. So if you have a less extensive protein framework, the minerals can't stick there. So the quality of the framework is of course important as well, and you need to think about this at least when you evaluate or when we as doctors evaluate the bone scans and the bone mineral densities, that this doesn't say it all when it comes to OI. Then we did the non-skeletal study. We call it, it's like the investigations of the hearing, the teeth, and the eyes. We had invited all the patients to an evaluation at the eye doctor, the ophthalmologist, and he looked at different issues. He looked at the corneal thickness and whether they had glaucoma or not. So eyesight is one of the most important of our senses. We know that several tissues of the eye contain collagen, and that eyesight is important to retain independence and probably also quality of life. We know in terms of OI that the sclera are blue, and we know also from previous studies that the corneas are thinner. Case reports suggest an increased risk of glaucoma, like the pressure in the eye, and occasional reports have reported retinal detachment and other things related to the eye. So the corneal thickness turned out to be lowest in the mildly affected ones. But all the people with OI had lower corneal thickness compared to a reference material that we had available. We found glaucoma in three patients in this cohort. Then we did some dental investigations. We had an experienced dentist to look at these patients, did photos, did x-rays and clinical evaluations, and we found dentinogenesis imperfecta in 27% of the cohort. And we found that the type of OI predicted most of these cases. So it was mostly found within the moderate and severely affected with OI. We did some other work looking at the dental data and found that people with OI were treated differently at the dentist, whether they had moderate and severe OI or milder OI. Then we found that they had more malocclusions and crossbite and overjet of the mandibulum. And the dentist discovered that pain was present, but actually not within the orofacial area, which is interesting. The hearing data looked quite similar to what Jannie showed us before. We found most patients to be affected by the sensorineural hearing loss. 52% of people with mild OI had some degree of hearing loss, and 25% of the moderately affected ones had some kind of hearing loss. The most profound, the most severe hearing loss was all found within the people with mild OI, reflecting that this is an important evaluation to make on a routinely basis, and at least if you have some kind of hearing loss. So we found the corneas of the eye to be thinner, reflecting the reduced amounts of the normal looking protein. Then we thought about this. Could this be used as some kind of test, diagnostic test? The mildly affected people with OI are the ones at risk of misclassification. And I haven't got any numbers for this yet.
So I just want to clarify, when you're using the term mild,
yeah,
type 1?
I mean type 1, and I totally agree with Dr. Sillens, you can't use it routine, but we've categorized them in type 1, type 3, and type 4 all the way through.
Right,
so yeah.
Mild is meant to designate that, whereas of course you would have people with type 1 who
Absolutely.
Yeah.
But it is type 1 and type 3 and 4, yeah. So whether it can be used as some kind of diagnostic test, we will need more evaluations of this, but it certainly showed the picture of that the cornea were quite thinner in this group of patients. So this would mean that a routine examination could be relevant at the ophthalmologist, at the eye doctor, to check for glaucoma, and we could consider the CCT, the central corneal thickness measurement, even though I can't at the moment say what the impact will be, but it could be relevant to consider it. The dental examination is recommended by experienced dentists. They were in doubt often. We have numerous of discussions. When I entered these studies, when I started these studies, I thought that a diagnosis of dentinogenesis imperfecta was easy and straightforward, but it's not. They discuss it as much as we as physicians discuss similar cases. So it needs to be in a team effort and experienced dentists. And then we need to remember the otologist or the audiometry. And in this cohort, we did these evaluations in everybody, despite previous hearing loss. The quality of life in this cohort, we gave all participants that entered the study a questionnaire, an SF-36 it's called, asking questions about physical health-related quality of life and mental health-related quality of life. And from the best of my knowledge, that's as good as you can give them questionnaires, but it will all reflect on the day you obtain the answers from these questionnaires. We had a control material available from the Danish population made some years previous to this, so we could compare it. And we asked them the same questions, and found that physically the scores that you obtain by looking at these questionnaires, they investigate physical function, physical role, body pain, and general health. And they were all lower in this cohort compared to the control material. The mental parameters were more similar to the control material, surprisingly similar, in fact. You can do a summary score of all the information that you get within these questionnaires, and here it's also quite clear that to the left, the bars with people with OI from this cohort had a lower physical score compared to the people without OI, but the cohort mentally, the cohort with OI were exactly the same as the cohort without OI. It turned out that walking distance was associated with a decreased physically health-related quality of life. It was questions like, can you walk the stairs? Can you do the shopping? Can you know, so it wasn't surprising, really. It turned out as well that educational level predicted an improved mental health-related quality of life. This is not in particular or special for OI. This is something that you see when you investigate in all different disorders. So, what does this mean? What is good health, and how should we define quality of life? That's again something that's really difficult. Is it the same when you have OI as in the general population? And should we have focus on the physical issues or the mental issues? I think as a physician, it tells me that we need to do all we can to improve the physical, all the physical measures, to try to prevent fractures, to treat pain, to work on mobility and that kind of thing, to at least improve the physical side of things the most. It's a general questionnaire, and it's got a number of limitations. We gave them, the participants, the questionnaire on the day they entered the study without asking about the current situation on pain. Had they lost their job recently? How was the family situation? That kind of stuff. So it could affect the results of a questionnaire like this. But it's very well actually in line with what previously has been written about physical disabilities. It's about some kind of balance between body and mind. How is it? What's the balance? Does it equal? Where are the challenges and that kind of thing? And an ability to cope with confronting problems. It's been shown in other disorders too, so it's not solely related to OI. We found in these studies relationship between the genetic changes and the skeletal phenotypes and the results from the scan. We found relationships between OI and the measurements of the corneal thickness, and between the teeth and dental changes and OI. And we found that hearing loss is frequent, and there's not really a relationship between OI type and hearing loss, but it's frequent in all types. And then we found differences between quality of life, comparing this cohort of OI with the Danish population. So in all, a study like this has a number of limitations, and we know who we saw, but we don't know who we didn't see at the study. So people could have chosen not to take part, and they did. Could be busy on work, or could be at home in pain and not entering the study. So it could be both. It's a rare condition, and research like this is always challenging. So should we look further into the three-dimensional structure of bone, it can definitely tell us something, and we need to be aware of these changes when we evaluate the scans. Is the clinical diagnosis sufficient? I think so. We are very fortunate nowadays to have all the genetic evaluations available, and we certainly rely a lot on them, but we need the clinical part to be on top of things. We don't find the genetic changes in all the patients. And then, could we refer to a simple eye examination to determine why? I don't think so, but it can be a step on the way. And then it tells us that collaboration between specialties is of extreme importance. And we've certainly learned a lot from this during this study, working together with the different specialties, and hopefully that'll improve in the future. Another thing that's been great doing this work has been collaborating with the patient society. We have established clinical meetings twice yearly where we meet up with 1 or 2 members from the OI Society, and then all the health professionals that are interested in OI sit around a table and talk. What's going on? Have we got any ideas? What's the problem? Are there any issues that we need to deal with? And this is an outcome of a large study like this, that we've got the collaboration established, and hopefully that will help us in the future. And then it can get us new research ideas as well. So prospectively, the follow-up in the adult population in Denmark, it's not there yet. We've recently moved to 2 older hospitals into a very, very big university hospital. So at the moment, or when I left, anyway, it was a bit of a mess, and it probably still is when I come back, we'll see. Moving a big organization like a hospital is a big thing. But we try to try to follow all adults with OI up routinely. It could be a yearly consult and a DEXA every 2 or 3 years from when they enter the adult department. Then we do eye examinations every now and then, and when needed, as well as we get the orthopedic surgeon in, use the dentist and the geneticist as much as we can. We haven't got the great resources that you have here in terms of physios and OTs. We could probably use them a lot more. And another thing that we found useful is to bring the adult physicians and the pediatricians together. So I, every now and then, go to the Center of Rare Diseases and take part in the consultations there, so we can share our knowledge and get to know the young people with OI before they actually transition into adult care. And hopefully it'll help. Time will tell. So in the future, the ideal thing would be to have all these different specialties that you'd need for follow-up under the same roof. I think that would benefit the child and the families and adults with OI, but we're not there yet. I'd like to acknowledge all the people that has helped me along the way, especially Lars Folkestad, who's together with me, has done a PhD on OI and has been extremely helpful and does a lot of work in this cohort. And thanks to you for listening.
Does anyone have any questions for Jannie?
Yeah.
Is there any association between your corneal thickness measurement and either bone density or fractures? You'd have to restrict it per group, I think, because the groups were so...
Yeah. I don't think so. I can't remember. I'll have to look into that. It's a good question. Yeah.
Hi, I just wanted to say how refreshing it is that you guys are focused on this. I think adults in Australia have exactly the same modus operandi, I guess. You turn 18, suddenly you're not involved with the children's hospital anymore. You know, there's the golf until something happens, and then you get kind of sucked in at a level which probably is more traumatic than if you've been continuing to see people as you go.
Yeah.
I really like that 5-year model.
And we try to individualize the treatment as much as, not to make people with OI should not be annoyed by coming to me or coming to one of my colleagues. They should feel that they get helped. So we need to individualize the treatment, and if that's just a talk every 5 years, then that's the case, and we can scan every 5 years, and that's it. But if some people feel more confident or more safe by coming every 1 or 2 years, and then that's what we're doing. So it's we're not there yet, but we're hoping to get there and improving. Thanks very much.
That initiative of collaborating with paediatricians and then with the Denmark OI Society would make massive leaps.
Yeah, I spoke with Carsten before coming here today, and he would have loved to join me on this talk and to be here today. He couldn't, of course, but it would be. That's something I find very special about OI, is all the patient organizations and all the great efforts and all the good work that's done with meetings across. They recently had a meeting on eyes and teeth and hearing in one of the Baltic countries, and they do every 3 years meetings with. So there's a lot of good things going on, and it keep impressed me how much the people with OI do about this themselves. So that's the one to thank, really.
Yeah, I definitely concur with that, absolutely. And just one other little big comment, the psychosocial aspects of a particular interest to me as well. I did a bit of research when I was doing my university postgraduate stuff around optimism and pessimism with OI, and found that pretty much, even though there was a perception out there that people with OI are more optimistic, that probably isn't the case. I mean, it would be a very small sample, but I didn't find anything there. But I did find something around anxiety for fracture. So if there is there was a small group of people that had quite high anxiety of fracture, but low actual fracture rate.
Yeah.
And then there was the other people that you want to be, which is high fracture rate but low anxiety.
Yeah.
So,
Absolutely. And maybe it's the fact that you live with that anxiety level, anxiety for the next fracture from your really small, and that must somehow affect your mental health or whatever. Nobody knows. It's interesting.
But I'm really pleased you were
absolutely.
You were actually addressing that.
Thank you. Yeah.
I'm nearly 70, and I was told to have a sixth sense about me from when I was very little. But I think we need to also look at connective tissue disorder, because I've had to face a lot of physio. I'm still waiting to face a lot of physio. Now, the physio doesn't work as quickly with us because our healing power is a much slower.
Yeah.
We get reflux because the stomach muscles get stretched, and it takes us. Now, you try and explain that to the physios, and it doesn't go down very well. So I think we whack a bit into, because I keep telling people it's a bone condition, but it affects everything in my body.
Yeah.
And they don't like this. Well, no one's telling them that, and they need to know it's a holistic thing.
Well, I think that's one of the reasons that I really support the idea of adults with OI getting followed in one place, because it is like such a systemic disorder. Even though it's the bones that are fragile, it's very very much a disease of the whole system.
And you know, but you've got to explain it's not just the bones. You're trying to heal both.
Yeah. Okay.
Do you have time for one more question?
Do we need to keep moving?
Yeah.
Jannie's going to be here.
I'll be here.
So feel free to catch up.
Absolutely. I think you can all appreciate that doing a presentation in front of a big group of people can be quite scary, but try doing it in your second language. I think you've done a really good job. Congratulations.
Thank you so much.
You've got some Aussie wine and chocolate.
Okay, thanks so much. Thank you.